Welcome back from the break. Our next session highlights some of the innovative programs that are changing the trajectory of families with substance use disorders. Each program will have about 15 minutes to present, and we will have about 15 minutes for questions starting about 11:15. If you have questions, please put them in the chat box and indicate which speaker you would like to respond. So we will start with the SHIFT program, which stands for Safe, Healthy Infants, Families, Thrive. First piloted in Maricopa County with the second pilot in Yavapai County, SHIFT builds a prenatal care network for expectant mothers with substance use disorder. I would like to welcome Meghan Hays Davis from Prevent Child Abuse Arizona and the SHIFT program in Yavapai County, and Clay Jones, the SHIFT coordinator from Maricopa County Public Health.
Thanks, Janet. Good morning. Hopefully everybody can see my slide. So Megan and I are here to talk about a really game-changing initiative in Arizona called Maricopa Shift, Safe, Healthy Infants and Families Thrive. And this is all about how do we treat these expectant women struggling with substance use in a collaborative, non-stigmatizing manner, and implement a variety of best practices. And this is across all systems. So think about all of the different entities that touch the lives of this population: treatment providers, medical providers, parents, attorneys in juvenile dependency cases, BCS, and so on. We've heard a lot about NAS today, and it's interesting, the overall birth rate in Arizona, like much of the country, has gone down significantly in the last 10 to 20 years. We're not having as many babies as we used to, but nonetheless, the net number of babies affected by NS has skyrocketed. So if we look at it per 1,000 births, you can see in 2009, this is statewide in Arizona, we had about 154. By 2020, it was up to 10 per 1,000. And the latest data we just got recently from last year, we crossed the threshold and now over 11 babies diagnosed with NAS per every 1,000 births, which translates to almost 900 NAS babies born in Arizona. And those are just the ones that we capture that we know about. Most of these are covered by Access, our state's Medicaid system. And one way to look at this is just the economic costs. These tend to be very, very expensive births. You can see the contrast, about $30,000 for an NAS baby versus $2,500 for non. So it's a tremendous drain on those resources. So what happens to these babies? So typically what happens in the vast majority of these cases at the hospital, if the baby's diagnosed with NAS, having those withdrawal symptoms, nearly all of them, what happens, they remove the baby from the parent, typically mom, place the baby in the NICU, and the baby begins a schedule of medication, typically morphine, to deal with the withdrawal symptoms. This is a couple of pictures of what a NICU might look like and a level 2 nursery. These are typically not particularly baby-friendly places. They're certainly not parent-friendly places. They can be loud, disruptive. And one of the challenges for this is it sends a message to mom that you're not capable of consoling your baby. We need the medical experts to do that for you. And this is what we do with, again, the vast majority of babies here. So then what happens? The baby's stabilized, and the report is made to DCS if they've not made one already, and they're working on discharge. If the baby cannot go home safely, they'll be placed in foster care, relative out-of-home placement. And when that happens, a whole lot of things happen very fast. The dependency case is initiated in court, parents are assigned parents' attorneys, and there's a whole lot of other system involvement that happens. We just heard earlier about Plan of Safe Care. Plan of Safe Care is a federal language that prescribes each state has to have a plan of what to do with SEN babies. In Arizona, that task falls on our Department of Child Safety, and our version of the Plan of Safe Care is called an infant care plan, is what we call it in Arizona. And so DCS is required to prepare this document, like was explained earlier with the Plan of Safe Care discussion, services for the baby, the parent dyad, you can see in these different 8 areas. So that's kind of the game plan as to what's going to happen with this baby. So here's where Maricopa Shift comes in, this new revolutionary way of looking at this. What if we engage these parents in collaborative, non-stigmatizing care and develop this care plan prenatally, right? So you're aware in Arizona, DCS typically does not get involved until after the baby's born. What if we started this work during the pregnancy, even the earlier in the pregnancy, the better? And so we developed what we call a prenatal family care plan, which is a document that mirrors the DCS infant care plan. The only difference is it starts during pregnancy. And that's a place where mom can document services, treatment, and so on. Might the outcomes be better? Might this make a difference? So back in Vermont, they're about 10, 12 years ahead of us. And we know it makes a huge difference. So their initiative is called CHARM, Children and Recovering Mothers. CHARM is the only SAMHSA endorsed initiative of this kind, of this cross collaboration across systems in non-stigmatizing supportive care with best practices. And so now some of the results that they're seeing are just astounding. So remember I was saying here, babies diagnosed with NAS are typically placed in the NICU, put on a schedule of medication, usually morphine. So that happens of over 90% of our babies. That's what happens. In Vermont, 80% of their NAS babies do not require any medication for NAS. It's reduced like 80%. They've seen an increase in the average birth weight, which really caught them by surprise. So that's not something they were really even thinking about or expecting, but the numbers don't lie. They see more and more babies going safe at home, lower cost per delivery. Remember that $30,000 plus per NAS baby. Using this model, costs are reduced by about 2/3, lower cost of systems, and here would be access. So the whole kind of secret sauce of this whole thing is prenatal enrollment. What if we get these moms engaged early on in the pregnancy, start coming up with a game plan, and everyone that touches the family's lives approaches them with non-stigmatizing supportive care that understands the facts, the myths, the reality of best practices in this. So this is what SHIFT is all about. I'm going to turn it over to Meghan Hays Davis of Prevent Child Abuse Arizona. She's going to talk a little bit about the statewide approach with SHIFT and where we're going.
Thanks, Clay. Yeah, so what's really great about SHIFT and the statewide approach is that it's just that. It's not a prescriptive program that tells you frequency, duration, or type of service that must be in place for this to be SHIFT. And so we're using this statewide approach and engaging different pilot sites across Arizona. So we have 3 pilot partners in Maricopa County: Clay's Department of Health, Banner University Women's Clinic, and Hushabye Nursery are our Maricopa pilots. And then we have 2 rural pilots, which is really cool work because I think oftentimes rural areas may get left out of these kinds of things. So we have our Yavapai pilot. And what's really cool is that this approach is really all about starting where you are with what you have. So in Yavapai County, our pilot partners up here are behavioral health, who provides SUD treatment already to these women and parents that they see, and home visiting. And now the health department is coming on board as well. So those are our partners. Those are all the doors that parents can access to really start getting involved with SHIFT. And I saw a comment earlier in here about pre-planning, and you are absolutely right. What we really want to do when we engage these parents early is connect them into resources, make those warm handoffs into prenatal care, substance use treatment, housing, WIC, all of the things we know they need, but also to prepare them for the great possibility that DCS will be called and they will be investigating at the birth event. And we know from feedback that we've had moms who delivered in Yavapai County who said, I had no idea, and thank you so much for telling me what that was going to look like, because I wasn't ready and I didn't know, but now I'm ready. And I'll tell you, in Yavapai County, very early data shows us that the handful of shift babies that have been born after we launched this, while they all had a NICU stay, every one of them went home with a parent after DCS investigated. So we're seeing really good early data in Yavapai County. Pinal County is our newest partner. They're doing it even more differently. They have developed a specialized hearing process for parents already involved in DCS, but who become pregnant again and have an SUD on board. And so they're doing that through the court system. Coconino County is probably our next partner, and they're exploring who their partners would be and all the doors that would be available there. So it's not prescriptive. It's really about how can your community support these parents prenatally to do that prevention work. So you can see our mission there, and you can see where we're going. Clay, do you want to advance? So here are system-wide best practices. We're really looking at universal screening. The one that we are using is the 4Ps Plus. This is developed by Dr. Ira Chasnoff. And if you've heard him speak, you know he's a subject matter expert. He is fantastic. So we're using this tool. It is validated. It is 60 seconds. It's conversational, and it covers alcohol use, tobacco, drugs, and domestic violence. So it's screening for all 4 of those in 60 seconds, and it can be done by almost anyone. We're also really focused on trauma and infant mental health practice. Clay and I are both infant mental health endorsed, and that's a big deal because we know that babies exist in the context of relationships, and that is the work that we must do. We also are strong believers in Eat, Sleep, Console. So instead of that NICU setting, we have hospital partners who are providing that, where mom is the treatment and baby and mom are still rooming in together. And we see much better hospital and health outcomes with that. We're also really focusing on non-stigmatizing and compassionate care. And if you've ever heard Tara Sundum speak, she talks about this. But when we learn a parent is pregnant and they have substance use disorder, it is very rare that we're saying to them, congratulations, right? And so we really want to think about how we are in this work as opposed to maybe who we are. And that is the game changer for our parents. And then we're also very aware of ethics and cross systems work in SHIFT. Next slide, Clay. I'm going to share this story with you. Clay's going to pop this video up of Clarissa. She is one of our SHIFT moms in Maricopa County, and it's a really powerful testimonial.
And a little bit about Clarissa. She's a mom that with her first pregnancy was struggling with SUD. She was not able to keep custody of that baby. Fast forward a few years, she's pregnant again, and this time she receives this kind of help that we're implementing here. And her and Callie, her baby's almost 3, and her fiance, and now Clarissa is a certified doula. She's a peer mentor, and she works at Hushabye Nursery with Tara and those folks. So here's Clarissa.
There's a new program called SHIFT. SHIFT can help you connect to different agencies all around the county. When I finally got help, I found all of these different services and all of these different agencies that can help me with education, with my recovery, with substance use treatment, the health treatment, not alone.
So that is Clarissa, really one of our many heroes in this work. I encourage you to, if you've not met her, go by Hushabye. They're on McDowell, right around 30th Street, and say hi and have a little tour there and see the kind of work that they do. It's really inspiring. And so we've got our contact information. Again, Megan's in Yavapai, pcaaz.org. I'm with Maricopa County Public Health. Our website is full of really valuable information, resources. Connect with us, make referrals. It's maricopashift.com. Every page on there is a page where parents or professionals can contact us via email or phone calls. So we're easy to find. And we've been going around the county and presenting on this for about the last year. So I've probably presented to several people that are on the meeting today. If I haven't presented to your organization, I encourage you to contact me and we'll get you on the schedule. It's about an hour-long Zoom PowerPoint to get everybody up to speed on this.
Clay, will you go to one of the last slides about the summit?
Oh yeah, sorry. Yep. And I forget that. There we go. There it is.
Thank
Summit.
you.
Go ahead.
One
Yeah.
thing PCA is really good at is convening, and part of our funding from Blue Cross Blue Shield and the Arizona Department of Health was able to provide this summit. And I put the link to the invite in the chat, and I saw someone on Whova mention it as well. But if you want to know more about this topic and you want to hear from some experts, we have a virtual opportunity on October 14th and an in-person summit opportunity on the 21st with Dr. Chasnoff. So if this lit your fire, please check that out and join us.
Thank you, Clay and Megan. I appreciate it. That was a great presentation. Now we're going to be talking about Eat, Sleep, Console. And I hope you were all able to join us for the special webinar we presented on July 28th. This is a promising new practice in treatment of infants who are substance exposed or suffering from neonatal abstinence syndrome. We are fortunate today to have an opportunity to hear about the experience of St. Joseph's Hospital as they implemented this innovative family-centered program. And we have with us today NICU veteran Cindy Walker to tell you about her experience, both the challenges and the rewards. Hi, Cindy, welcome.
Thank you, Jeanette. Thank you. So like Jeanette said, my name is Cindy Walker, and I am an RN working in the nursery ICU at St. Joe's Hospital in Phoenix as a developmental specialist. And I also serve as the developmental education and training consultant for ADHS. And today I'm going to tell you about the experience that we at St. Joe's had using the Eat, Sleep, and Console model to care for our substance exposed infants and the effects that using this approach has had on our babies and their families. If you don't know, St. Joe's is a large hospital in essentially downtown Phoenix. We average more than 400 deliveries every month. The nursery ICU itself is 72 beds, although our average census is usually in the mid to high 50s with around 66 admissions every month. About 80% of our patients are on access. The number of babies admitted to our unit who have NAS as a diagnosis varies each month. So we can go a couple of days in a row with no substance exposed babies in the unit. And then we have days when there are as many as 9. And as you know, these babies can be difficult to care for and be a handful while they're in the hospital. They are labor-intensive patients and require many hours of manpower in order to care for them the best way possible. And this manpower can be provided by staff, but it is of course best when it is provided by the person or persons who will be caring for the baby after discharge. And that person is hopefully mom. So that's our goal at all times, to actively engage the folks who are going to care for the baby in the long term. We want to send the baby home in their best possible state with the people who are also in the best possible position to continue to care for these special babies for a lifetime. We started our ESC journey at St. Joe's about 4 years ago. We recognized the need to have an approach that better served our babies with NAS. We had babies that were staying way too long and moms and families that were not being served as well as they could be. We put together a multidisciplinary team and began meeting to have discussions about how to start. Because of my work as the ADHS consultant, I was aware of the work that Banner UMC Tucson had begun using the ESC model. So we packed up and traveled down to Tucson to meet with them. They had started their ESC program about a year before we went, and we wanted to see what had worked for them and what their challenges had been. When we took that information, and we began to see how we could make it work in our hospital with our staff and providers and with our babies and families. And we knew it was a big task, but we were determined to do our best. So for a little context, I'm going to tell you about how things were done before we began using ESC. For the most part, substance exposed babies were admitted to our unit very quickly after delivery, usually while mom was still in the hospital. The baby came to the nursery ICU and became a nursery ICU patient. Now, if you don't know what that means, let me explain. The babies were put on a very tight schedule with assessments and feedings done exactly every 3 hours around the clock. No sooner, no later. We used the Finnegan scoring tool to assess the baby's withdrawal symptoms. So every tremor, sneeze, and yawn was recorded. If the baby cried, the nurse attempted to quiet the baby with a pacifier and maybe some sucrose. She tried to wrap the baby up tightly with their arms at their side so they wouldn't startle as much and wake themselves up. And she dared anyone to come near that baby if the baby was asleep, knowing how much work it would be to get the baby back to sleep if someone came in and woke them up. Now, this really wasn't done to be mean, but it was really done out of necessity. The nurse had other babies to care for. She needed to chart and hang IVs, and she probably even wanted to eat at some point and maybe even use the restroom. So a baby who didn't follow the schedule, who wanted to eat every hour or who woke up every hour and who cried except when they were held was very difficult to manage some days. So what did we do? We medicated them a lot. We put them on morphine and clonidine and even added in some phenobarb sometimes, every 3 hours, no matter what. Even if they were sleeping, we squirted the medication in the side of their mouth, put their pacifier in, and encouraged them to swallow it in hopes that this would buy us a little more time of them being asleep. And when the provider came around, we said, absolutely not, this baby cannot be, the dose cannot be weaned, because the baby was jittery or sneezed or spit up. And we tended to overfeed them in the hopes that they would sleep a little bit longer. And we really hoped their pesky mom would not show up. I mean, why would we want her there, right? She's the one who did this to them. She would just want to wake them up if they were sleeping and had no idea how to get them back to sleep again and couldn't feed them. We had the mindset, like you just heard, let us take care of the baby. We'll let you know when the baby's ready to go home and you can come and pick them up. And then good luck. And the average length of stay for these babies in our unit was 27 days. But we had babies in our unit for upwards of 60 days. And we had families who were afraid to visit because of the way they were treated by the staff. And we had very frustrated and unhappy staff. So when we got back from Tucson, we continued to meet weekly. We gradually have spaced them out, but even today, we still continue to meet monthly to discuss any new ideas or ongoing issues. Our medical director in the nursery ICU, as well as our attending who oversees the pediatric residency program at the hospital, are at every meeting. We have our nursing leaders present. We have bedside nurses and our nursery ICU therapists, including OT, PT, and speech. We included our social workers and even our chaplain. Our pharmacist developed a medication tool that we now use for every NAS baby if medication is needed. The tool outlines the dosage and the weaning schedule. It also includes a PRN, or an as-needed dose, that can be used if needed. We developed many other protocols and policies surrounding these babies, and we presented them to the hospital pediatric committee and to the hospital administration. And then we started the process of educating staff. Initially, we decided to continue using Finnegan, the Finnegan scoring tool, for symptom-based approach for the babies who did not have a dedicated caretaker for them in the hospital. But we would use ESC for babies who had a parent or the person who would be caring for the baby at home present in the hospital. We did this for about 3 months when we realized that this was very confusing for staff and providers. Many staff would score using both tools, and even if the baby was able to eat well, sleep well, and was consolable, they would say, yeah, but if we were using Finnegan, the baby would score, whatever. So that even if the baby was able to function appropriately, we remained worried about what the symptoms of the NAS withdrawal were. So then we decided we just wanted to worry about the baby's ability to function as a baby and we changed and we began to use ESC for all the babies with the diagnosis of NAS. So using ESC was obviously a very different way from how we had assessed these infants in the past. We wanted the babies to eat enough to grow, to sleep at least an hour at a time, and to be consolable within 10 minutes. The education taught our staff how to use ESC to score, but it went further than just the how-tos, more than just the numbers. We also really tried to affect the culture in our unit. We talked extensively about how these moms felt judged, how hard it was for them to see their baby, who they really did love, go through this withdrawal, how they felt guilty about what they had exposed their baby to, how they were scared to death about what DCS involvement would look like and what it would mean for their baby. Would they get to keep their baby or need a safety monitor, or would they have to say goodbye to their baby in the hospital? Navigating all these things with mom is not easy on the staff. Sometimes, as hard as you try, it's really difficult to not be frustrated with these moms. They just don't seem to always do exactly what we want them to do. And in cases when they don't seem to care at all, it's really hard. So we have concentrated and learned to try our best to meet mom where she is. We have to try to foster whatever bond is there. We have to accept the mom and teach her to care for her baby. We have to try to understand her actions before delivery and after too. Our goal now is to keep mom with her baby as much as possible. We start this immediately after delivery by keeping the baby with the mom in her room on the mother baby unit as long as possible. The mother baby unit staff also use ESC to assess the baby. This helps tremendously because if and when the baby has to come to the nursery ICU, the mom is already aware of what the staff is looking for in the baby. We want mom to bond with the baby and to be the one who holds the baby as much as is needed. The baby is moved to the nursery ICU if mom is discharged and the baby is not ready to go home yet. And of course, the baby must also be moved if the withdrawal process requires the use of medication. The baby must be monitored closely if medication is administered, and this cannot be done on the mother baby unit. But remember, medication is now the last thing we try, not the first. We stress the use of non-pharmacological interventions. We want the baby to be held by mom. We often say, like we've already heard today, mom is the medicine. We use motion beds and infant swings. We have noise machines that provide sound that is comforting to the baby. We utilize our therapy team of OT, PT, and speech for extra hands. And now, after a long absence due to COVID, I'm happy to say our volunteers are coming back, and what a godsend they are. Their main purpose is to hold these babies whenever mom is not available. But now we fully expect mom to be around as much as she can. We actually encourage her to spend time with her baby. We make her as comfortable as we can with the restrictions we have due to the nature of our unit's environment. We use our step down area as much as we can for these babies so they don't have to be in the busy ICU where it's active and loud. These babies are given priority in the few private rooms that we do have. We encourage moms to provide skin-to-skin holding. We encourage mom to breastfeed as long as her toxicology is negative for everything that she's not prescribed. We want her to feed the baby on the baby's schedule when the baby is hungry. We even can provide food vouchers for her if necessary. We have learned that mom's basic needs must be met in order for her to best be able to care for her baby. And if she is concerned about when she will eat next, she won't be able to put 100% into caring for her baby. So fast forward to today. We still have challenging babies in heavy assignments sometimes. We still have challenging social situations that are hard on staff, but our approach has changed. And to date, we have had many tremendous success stories. Our length of stay pre-COVID was as low as 7 days. But full transparency, with no volunteers, our length of stay has increased to around 12. But like I said, our volunteers are slowly returning. So our goal is to get back to our pre-pandemic levels as soon as possible. Our use of morphine is drastically lower than it was before we started. And we have a plan in place with a weaning schedule that assures the baby will be off medication in as the most it will ever be on is 8 days. And we don't use any additional medications at all. But most importantly, we are sending babies home with families who have been taught everything they need to know to care for their baby for the long haul. They become the experts and the ones who feed their baby the best. They know how to bathe and diaper and swaddle appropriately. Our moms feel powerful and they know how to be advocates for their babies. We have adoptive parents come and stay for days in a row, loving and learning to care for their precious baby. Our effort to teach and support, no matter the circumstances, is remarkable. Are we perfect? Not always, but sometimes we are. And we're more successful than ever in sending home a prepared mom and a regulated baby. We have given mom the tools she needs to help her baby right now, and maybe even later when they're colicky and teething. We have increased the chances of both of them being successful down the long road. And we're proud of ourselves when it works out just the way it should. Thank you for letting me present our journey at St. Joe's with you today. We will never stop trying to provide these special babies with the best care right from the start. Thank you.
Thanks, Cindy. That just warms my heart to hear about this program. Next, we have DCS. In 2006, the Department of Child Safety created the Substance Exposed Newborn Safe Environment, or SENSE program, to provide services for families after the birth of a substance-exposed infant. The goal of this multidisciplinary coordinated service delivery approach is to ensure children's safety and needs are met and support behavioral changes with parents by bringing together a service team of support. From the Department of Child Safety, we have Lauren Zanotti, the statewide services coordinator, Vicki Berry with Family Connections, and Brandy Madrid, a SENSE nurse consultant. Take it away.
Thank you so much. Yes, today we will be discussing the supporting women and families with substance use disorder during and after pregnancy, and specifically the DCS SENSE program. So what is the SENSE program? The Substance Exposed Newborn Safe Environment program provides support for families after the birth of an infant that was exposed to drugs or alcohol during the mother's pregnancy. The SENSE program is provided by a team of supportive people, and we do like to remind everyone that it is a voluntary program for DCS families. So what substances qualify? Marijuana with or without a medical marijuana card, illicit drugs, things like cocaine, heroin, methamphetamines, fentanyl, etc., alcohol, and prescribed medications. Eligibility for SENSE. So there needs to be an open DCS case that was generated by a report to the hotline. And then the infant is born substance exposed in utero per DCS report for any or all of the following. The newborn tests positive at birth, the mother tests positive at birth, the parent reports drug use during pregnancy, and or the mother tests positive for drugs during prenatal visits.
So our SENSE team members include Family Connections consultants, Arizona Families First, also known with the Families in Recovery Succeeding Together, also Early Child Development home visitor, and a registered nurse, and certainly DCS. I don't need to read off this one, so I'll just kind of expand a little bit more. So really with the family, we are looking at the family participation by sharing openly with providers as to what is working well for their families, along with their needs, their worries, concerns, and really their stage of readiness of change. Again, DCS really determining that safety, developing that infant care plan, oversight of the case, and any safety plans that may need to be implemented. The Family Connections Consultant, really that service is a focus that is important to really working within child safety and well-being by strengthening the family functioning, utilizing protective factor framework, which I know we've talked about throughout yesterday and today, to help build that parental resilience, those social connections, those concrete supports, and parenting attitudes and behaviors to strengthen those behaviors and knowledge of parenting skills, developing and building those social and emotional competence of their children. We also have the nurse, the registered nurse that goes out to do home visits. They're assessing the infant's overall well-being, ensuring that the infant is living and sleeping in a safe environment. Parents and baby are attending follow-up appointments, well-child doctor appointments, also implementing screening parents for postpartum depression and intimate partner violence, and providing and discussing educational handouts, and additionally completing any appropriate referrals that are found to be needed. The home visitor component of it is really an additional support so that we know that our families will have and be involved in a long-term program, so that once DCS is no longer involved with the family will continue to be connected within the community, receiving that emotional support, education, and really encouragement, child development screenings, activities, and that promotion of parent-child interactions and relationships, and really linking families to other community services to continue building overall family self-sufficiency. Also, another component is that Arizona's Families First, the Families in Recovery Succeeding Together. So a substance abuse treatment is a family-focused treatment. This program is aimed to ensure all supports are involved in the parent's treatment, not just the person who is diagnosed with a substance use disorder. So the goals, general goals, the goal is to keep the infant in the home while the parent learns about child development and parenting, and succeeding in the recovery with substance use. Also, the team members will communicate with each other frequently to coordinate those services, and will communicate with the DCS specialists about the family's strengths, needs, and progress. And the program aims to keep the infant in the home while the parents work with service providers, really to learn those new skills and work with them to maintain their sobriety. I think really for us, a big take-home message is this is really a family-centered and supportive service that is comprehensive, coordinated, culturally responsive, and provided in the family's home. Services are individualized and they're tailored to each family's individual needs, and focusing on keeping the infant home safely with the parents, supporting that bond attachment relationship, while the parents focus on the following, parents focus on the functioning of the family along with maintaining their sobriety. Parents, children, and their family members are the experts on their own families and have the potential to change, and are engaged to find the solutions within themselves.
All right, so part of the program, as Vicki stated, is an RN does go out to see the family. They do see the family within twice during the program. The program is designed to last 150 days. So when the nurse goes out and performs the assessment, these are follow-ups that we sometimes see with our families. As you can see, the biggest follow-up needed is the postpartum visit, which that's with our families, as well as I think the general population. We know that postpartum visits are down across the board, doesn't matter who you are, as well as the infant follow-up visits and unsafe sleep. So really our job is to find out why. You know, with these families, as many have stated, there's a huge stigma. They feel bad. The doctors aren't always the nicest to them. So we really focus with the nurses to find out why. If they haven't gone to their visit, is it because they do feel judged? Is it because they don't feel comfortable? Let us help them find a provider that we know does treat women with substance use disorder, so that it is more comfortable and they know that there's no stigma or judgment at this office. So we focus on that. Unsafe sleep is a big thing. Our nurses do lay eyes, as well as the family connections coordinators and the DCS staff. We do lay eyes on where that baby sleeps. Again, I think this happens among everybody. It's not just our families, but it's very important to go over safe sleep and to really lay eyes on where the child is sleeping. And then we wanted to include a slide. A lot of people ask, well, how do I get my family enrolled in SENS? How do we do that? If mom is still pregnant and using substances, she can actually call the hotline, and it's called an unborn concern. And that means she's still pregnant. She can report to the hotline. If baby is born, then you can report to the hotline at that time as well. And then based on the screening with the hotline, then, family would be referred to DCS and have an in-home program. As Vicki stated, this is a in-home program. This is a family with mom and dad or parents. The baby does have to remain in home with the family, and really want to focus on, this is not a punitive program. This is really a supportive program. It's wraparound services. We listed all the different components of the program. It really is a great program, and it does work. And it does provide families with everything that they need to be successful.
I apologize. I don't know what I've done here, but our next slide was our contact information, which we'll be able to put into the slide. Into the chat, I'm sorry. There we go. Hopefully you guys can see this. I guess not. I apologize.
You can also put it in the chat if you'd like. It's not as bad as having Alexa start talking during your presentation. Are you guys ready for questions? Okay, great. All right, then I'm going to move on to the questions that we've gotten. And here we go. Okay.
That's the question.
Pardon? Oh, we've got several. Okay, is there research data available on charm outcomes? And that was from Sherry Lanigan for Clay. And Clay already put the link in the chat, but if you're wondering about that, it's in there. Is there a long-term observation monitoring for outcomes and safety at home? And this is for Megan and Clay.
I would toss that to DCS. That's something more once, the child is home and so on. Again, SHIFT is a collaborative of the actual partners that are doing the actual work. And so in that case, DCS would be the ones involved. If there is an in-home dependency, say in that case.
Mm-hmm.
Does that make sense?
I would add that they may end up working in the SENS program, or they may not.
And we have a question here. It says, where is the SENS program still operating? We were partners on the team in Cochise, but have not heard from them in a while.
Well, I guess I can speak to that. Statewide, census statewide. If anybody, we actually do a Sense collaboration meeting. We're trying to do those quarterly. So if anybody wants to be involved in that, certainly they could email Lauren, myself, or Brandy. And we can include on an invite, because it is very imperative that we have community support. And working within certainly our rural areas, we need an additional support. So if you would like to have an invite to that, we would certainly be glad to forward that information to you.
Okay. And then we have safe sleep seems to be one of the causes of infant death. but we haven't seen any changes when it's presented. So what can we do differently?
I can go ahead and at least give my opinion on this one. Ariel, the posters do change, right? The information is the same. It's alone the ABCs, you know, really to me, how can we change it? How do we do it differently? We just keep educating it. It's everyone's responsibility to talk about it. And we can't change people. All we can do is provide them the education. And I think it's just really important showing the numbers, showing how common it really is, and teaching them how to do it differently. Because we can go into a home and we have cultural situations where they've always done it, or the baby lays in a certain environment because that's what's been done for generations before. So we have to educate them on the safety and how that's not safe for the baby, and teach them so that they know better. And I feel like that's how we really can make a difference is educating them, not disciplining them, but educating them so that they understand what the thick comforter is doing in the bed, what the toys could possibly do, because sometimes it seems silly. But if we explain the why of it, I feel like that really helped.
Okay. And then this question's for Clay and Megan. It says, how can we get shift in other counties?
Me. You can email me directly, megan@pcaaz.org, and I can put it in the chat. We are looking at partnerships in other counties and how we can support the collaborative work you may already be doing.
Great. And then this question is for Cindy. It says, has that decreased the workload on your staff since implementing Eat, Sleep, Console?
Well, that's a really tricky question to answer. We try, at least at the beginning, when those babies first come in, their withdrawal is the most active, to keep them in a less ratio assignment. So that nurse might only have 2 patients rather than 3 or maybe even 4. But it just really honestly depends on our staffing and if we are able to do that. Our workload is definitely less with those babies when we have the extra hands, when we have our therapists who are available, when we have our volunteers available, and really when mom is available. Mom is really our best nursing aid in that type of situation. But it really just kind of depends on, you know, unfortunately, we still have to staff the unit. We have to care for all the babies. So we try, but it just does not always happen that way.
Okay, thank you, Cindy. This question is for Vicki or Brandy, and it says, is sense evidence-based?
It's so hard on a team of 3 who's going to respond first.
I can
So
just
I will take the question. So the sense program itself is not an evidence-based program. However, we do, part of the programming is like family connections, which is that home visiting component, which is an evidence-based program. Also Arizona Families First, obviously there is some nuances within that, is also because it is a substance use treatment, which is for that evaluation and identifying what treatment, if any, would be the recommendation. So the SENSE program as a whole is not, however, the different components within it can be. Hopefully that clarifies.
Okay, and then Christine Ellis had a question for Vicki and Brandy as well. It says, at what point during the pregnancy is the SENSE program started?
So because in order to be referred for the SENSE program, typically that will either be generated because a report came into the hotline because that was reported. So it would not be prenatally. There has been situations that maybe we're already involved with the family and then we become aware. So there is a potential of referring that program for a family as well. But obviously we do have to already have an open case with the family in order for them to be referred for that. And it is, the family does have to be in home. So we sense is not a program when children are out of care. So the idea is really to try to stabilize and provide a wraparound service so we can do all that we possibly can to maintain the family in a connected situation while also being a very safe environment.
Thank you. And I just want to thank all of the presenters this morning. This was such a great opportunity to see some of the really innovative, great programs we've got in Arizona that are striving to really meet the needs of these families.